clinical scientist with 25 years of service to the discipline of hepatology, with special expertise in the disorders of iron overload, liver transplantation, and viral hepatitis. He is the past president of the APASL and remains a member of its steering committee. He is a past president of the Gastroenterological Society of Australia and the past chair of the Australian Liver Association. Professor Hans Lin is currently the president of the Taiwan Association for the Study of the Liver, TASL. He is a senior attending physician at Taipei Veterans General Hospital and a professor at National Yangming Chiao Tung University School of Medicine in Taiwan. Dr. Lin has deeply involved in the research of pathophysiology of cirrhotic portal hypertension, liver fibrosis, and the complications of cirrhosis. He had continuously received the research award of professor grade from the National Science Council for 10 years. He served as an associate editor of a Journal of Hepatology and Liver International. I wish all of the panels and the attendees to participate actively to the discussion during the session. Please use the chat box at the bottom of the screen to send us your questions and the comments. Thank you very much. And Professor Crawford and Hans Lin, please.
Thank you for that kind introduction, Professor Lim. On behalf of Professor Lin and myself, I want to congratulate you on putting together an excellent program for this webinar. So I'd like to therefore introduce our first speaker, Professor Sin from Samsung Medical Center, to present a case presentation of a case of chronic hepatitis B with rising alpha fetoprotein.
Thank you, Professor. So I will present a case of a chronic hepatitis patient with rising serum alpha fetoprotein levels. So the case is a 69-year-old male with chronic hepatitis B infection. He has been treated with antivirals since 2003 and heavily treated. And currently, he was taking tenofovir. So this is his laboratory findings and ultrasonography finding at index visit. You can see the platelet level is normal. Normal prothrombin time, albumin level is also normal. Normal bilirubin levels, and ALT level is below the upper limit of normal. And his viral HBV DNA levels are well suppressed with antiviral therapy. And here is, right panel, you can see his ultrasonography finding. There was no ascites or no evidence of overt cirrhosis. So he is an old man with chronic hepatitis B infection. So he has been receiving HCC surveillance in regular basis. And here is a summary of his surveillance exams. And his serum alpha fetoprotein level was continuously rising from 1.3 to 3.8, although the level was still below the upper limit of normal. And every time he received CT or ultrasonography as a radiologic surveillance test, and which was all called negative. Here is a surveillance exam 2.5 years before. Alpha fetoprotein level was 1.3 and CT surveillance was negative. And 6 months before, his serum alpha fetoprotein level was 3.8 and the CT surveillance was also negative. So here is a summary and question for today. This is a 69-year-old non-cirrhotic male with chronic hepatitis B under antiviral therapy. The persistently normal ALT level, undetectable HBV DNA, a steady rise in serum alpha fetoprotein level within upper normal limit, and no suspicious nodule by imaging studies. So the question would be, what should we do at the next visit of the patient? Thank you.
Thank you, Dr. Singh, for your case presentation. So we will welcome our first speaker, Professor Amit Singhal, to give a talk about the principle of cancer screening and the necessity of tailored approach to HCC surveillance. Professor Singhal received his MD degree from the University of Michigan, Ann Arbor, and currently he's the professor of medicine at UT Southwestern Medical Center. And Professor Singhal, please.
Yeah, I'd like to thank you, Dr. Lin and Dr. Lim, for inviting me here to be part of this APASL webinar. It's an honor to be a part of this esteemed panel of speakers. As you stated, today I will be focusing on two different aspects of HCC surveillance. I will start the talk by discussing the principles of cancer screening, and then the second half of the talk will be discussing why we should be really moving towards tailored approaches to HCC surveillance. Here you can see my disclosures. So to start, like many talks, I'm just going to go over the basic epidemiology of HCC. We know that this is the third leading cause of cancer-related death worldwide. And we know that the highest burden resides in parts of East Asia as well as Africa, driven by high rates of endemic hepatitis B in both of those areas. In the Western world, including the United States and Europe, we know that it has more of an intermediate incidence and mortality rate, although we are seeing increases in mortality in many of those areas as well. Here we can see the most recent figure from the BCLC, and we know that when you take a look at this overall, there are dramatic differences if you find this tumor at an early stage versus a later stage. If you find this at an early stage, we know that there are curative therapies available, including local ablation, surgical resection, liver transplantation. And these therapies can afford very long-term survival with a median survival well over 10 years for many patients. Although we have seen improvements in treatment strategies for those patients with larger tumor burden, as well as implementing the concepts of downstaging, these patients typically still have much worse survival with a median survival somewhere between 1 to 3 years. And this marked difference in survival really underlies the recommendations from several professional societies, including APASL, the AASLD, as well as EASL, to recommend HCC surveillance in high-risk individuals. The recommendations across these different societies are very similar. Most of them recommend ultrasound-based surveillance with or without AFP, although I think the APASL guidelines have been slightly ahead of the other societies in terms of incorporating alternative surveillance modalities as well. Now, when we think of the principles of cancer screening, and this is where I really want to start here, the first principle here is that the value of cancer screening really must not only consider benefits, but must consider the balance of benefits versus harms. Benefits are typically defined as early stage detection and most notably improvement in mortality, but this must be weighed against different types of harms, as we'll talk about. When we take a look at the data for HCC surveillance benefits, as many of you know, the best data for benefits of HCC surveillance continue to come from a large randomized control trial that's now over 15 years old. This randomized control trial included over 18,000 patients from China that had chronic hepatitis B, randomized to HCC surveillance or not. And the patients that were randomized to HCC surveillance had significantly higher early detection, significantly higher curative treatment receipt, and most notably, this continues to be the only level 1 data that we have that HCC surveillance can reduce HCC-related mortality with a rate ratio of 0.63. In patients with cirrhosis, we do not have a randomized trial. When one was attempted in Australia years ago, this had to be stopped given poor enrollment given a lack of desire by both patients and providers. And so we're forced to depend on large cohort studies. This is an updated meta-analysis that is recently accepted into Journal of Hepatology, in which we summarize the most recent data for the benefits of HCC surveillance. We find in contemporary studies that HCC surveillance continues to be associated with significant improvements in early stage detection, curative treatment, and overall survival. With the forest plot shown here on the right-hand side of the slide, a pooled hazard ratio of 0.64, so a 36% improvement in survival in most recent contemporary studies looking at the benefits of HCC surveillance. Once again, we have been cognizant that these benefits must be weighed against screening-related harms. This is an accepted rubric for classifying screening-related harms into 3 different types of harms: physical harms, financial harms, and psychological harms. And you can see that these types of harms can be related to the screening tests themselves, as well as the follow-up tests, and really can extend, to different types of harms, including complications, or, for example, financial harms, even including indirect costs of missing work. Now, when we take a look at the literature characterizing HCC surveillance harms, we find that there's a dearth of literature currently evaluating HCC surveillance harms. There are only 4 studies to date with a total of 2,500 patients, and you find that those studies report a wide variation in harms between 9% and 28% across studies. However, most of those studies find that the harm appears to be mild in nature. Most of those harms are just having a single CAT scan or MRI, so those harms, once again, are in the acceptable range. There are currently no data on financial harms or psychological harms of HCC surveillance, so these data are still needed. The other type of harm that I think is increasingly recognized, maybe poorly understood, and we do need more data in terms of HCC, is overdiagnosis. Overdiagnosis is the concept that you may identify HCC cases that have a more indolent nature, or these patients have high competing risk of mortality. And so these HCC cases never would have impacted that person's overall survival course, i.e. you diagnose the case, and even if you treated it or untreated it, that patient would have died at exactly the same point. These data are increasingly necessary, particularly as we recognize that HCC is not uniformly an aggressive cancer, and that up to 25 to 30% of cases may have a more indolent tumor growth pattern, as suggested by more contemporary studies, as well as a meta-analysis looking at tumor growth patterns among patients with HCC. Now, I'm going to, for the latter half of my talk, I'm going to take this principle of value of both benefits and harms and talk about how can we put this onto HCC surveillance and how can we improve overall value. And I think this nicely ties into this concept and this desire to move into a strategy of precision surveillance. This was a review article that we published a couple of years ago that talks about how we could improve the value of HCC surveillance. And I'm really going to be talking about all 3 different aspects, but I'm going to be focusing on the right-hand side of the slide, talking about predictive biomarkers as well as different surveillance modalities, looking towards a precision surveillance strategy moving forward. So what is precision screening? Simply, precision screening is applying the right test to the right patient to maximize the benefit to risk ratio. At this time, one can imagine the one-size-fits-all has a favorable benefit to risk ratio in high-risk patients, but less favorable in lower-risk patients. And if we better understood risk as well as different strategies, we could apply more intensive surveillance modalities with higher sensitivity to those highest risk patients to maximize value. So what do we need to move towards a precision screening strategy? The first is that we need to do a better job at identifying high-risk patients. And then the second is that we need options for different surveillance modalities. So I'm going to start by identifying high-risk patients. At this time, we currently have a one-size-fits-all strategy where we essentially have established at-risk populations, including subsets of patients with chronic hepatitis B, I think all of us know those subsets well. And then we have cirrhosis from any etiology. These patients are all currently recommended to undergo HCC surveillance across the board. However, we do recognize that not all patients are equal risk. There have been very nice risk calculators that have been developed, more so in chronic hepatitis B than in cirrhosis. But for example, the modified PAGE B score based on age, gender, platelet count, and serum albumin was evaluated in over 3,000 Asian patients with hepatitis B on antiviral therapy. And you can see very nicely stratifies risk with a C statistic of 0.82. And this highest risk group having a 5-year HCC probability of 18% compared to a 5-year probability of only 0.7% in the lowest risk group. Similarly, there have been risk scores established among cirrhosis patients. You see one example on the right-hand side here, a risk score using age, sex, BMI, diabetes, platelet count, albumin, and AST to ALT ratio. And in a cohort of patients with cirrhosis from alcohol-related or not NAFLD cirrhosis, we see that this does risk stratify patients with reasonable accuracy, a C statistic of 0.74, and very good calibration in the validation cohort. I raise these not as the answers, but more so as concepts that we do have clinical risk scores moving forward, although we can see that the C statistics of 0.74 and 0.82 still have room for improvement. I would say that clinical risk features are probably not the answer. They probably can't do this perfectly, and we do need better risk biomarkers. This concept was first pushed forward by Yujin Hoshida and his group identifying a tissue-based transcriptome that was able to accurately risk stratify patients with cirrhosis, validated in thousands of patients, and was able to accurately risk stratify people. The main issue and limitation there was that it required a biopsy to obtain tissue in the past. His group recently surrogated a blood-based biomarker that also was able to stratify patients into high risk and low risk groups using a blood-based biomarker now, so much more feasible to implement in clinical practice. They are now moving this forward in terms of having add-ons. So for example, they would have a NAFLD add-on that would further be able to risk stratify these people. So this is an interesting concept that is being moved forward. So I do think we're going to see blood-based risk stratification that can be combined with these clinical risk scores and able to better stratify people moving forward. Now, the other part of this that we would need is options for surveillance modalities. As I said, most current guidelines recommend ultrasound with or without AFP. I think there has been increasing recognition that ultrasound alone is not the answer. This was a systematic review and meta-analysis of the literature for ultrasound alone to detect HCC at an early stage. We can see two different things. The first is ultrasound clearly operator dependent, huge variations in sensitivity for early detection, ranging from 21% to 89% across academic centers here. And overall, the pooled sensitivity of ultrasound alone for early detection is insufficient, with a pooled sensitivity of only 47% if you use ultrasound alone. If you add in AFP, you are able to observe significant increases in sensitivity for early detection, 63% versus this 45%. And when you incorporate these most recent data for the performance of ultrasound alone versus ultrasound with AFP, we find that ultrasound with AFP is the most cost-effective strategy in over 80% of simulations. So ultrasound with AFP, I would argue, is the current gold standard for HCC surveillance modalities, although a sensitivity of 63%, as I referenced, leaves a lot of room to be desired. Now, you're going to hear from Dr. Toyota later today about different biomarkers that are coming out for HCC surveillance. I list some of them being here, but you're going to see very exciting data for several of these biomarkers, including GALID, which has recently undergone phase 3 evaluation presented at the AASLD. We've seen methylated DNA marker panels that have been validated in a multinational case control study. We've seen circulating tumor cells also start to come out. We're going to see more validation of these because there now are several cohort studies allowing biomarker banking and quick validation in a phase 3 retrospective cohort manner. So I think the nice thing is that we're going to see many of these biomarkers with hopefully high sensitivity and specificity come out over the next several years. And so we will have other biomarkers that are possible. Similarly, you're going to hear a very nice talk by Dr. Kim taking a look at the different imaging studies that may be available for HCC surveillance. I'm not going to go through this study in detail because this is, her study that she and Dr. Lim, among other colleagues, performed several years ago now with in a prospective cohort of over 400 patients with hepatitis B cirrhosis. And I'm sure she will provide the details, but very nicely showed that MRI was highly sensitive, highly specific in this cohort of patients. This has subsequently allowed evaluation of other MRI-based modalities, including abbreviated MRI. And this also offers other imaging modalities that will also be available as we move forward. And I think overall, thinking back to this concept of precision screening, this was a proof of principle cost effectiveness analysis that we published a few years ago, taking a look at what could be possible among a cohort of compensated cirrhosis, incorporating preliminary data on these risk stratification biomarkers, and then applying different surveillance strategies. And in brief, what we showed in this proof of principle study here is that you can identify low-risk patients using this risk stratification strategy in which the risk can be low enough that you can avoid HCC surveillance. And in those highest risk individuals, you can actually make it so it's cost-effective to use MRI-based surveillance, including abbreviated MRI. And in those intermediate risk patients, you may combine ultrasound and MRI to maximize cost-effectiveness. And overall, this was cost-effective at this. I'm going to add a figure where I'm going to talk about HCC surveillance underuse. It's clearly recognized that HCC surveillance underuse is a problem. So HCC surveillance underuse, pooled estimate, only 26% in this meta-analysis, and this is true across all study settings, whether you live in the US, Europe, or Asia, although Asia clearly doing much better than the US in terms of surveillance utilization, but clearly a problem across the board. And this was a study that we published this past year, taking a look at this concept of precision screening and applying this to interventions to increase utilization. So in this study, what we did is we leveraged a randomized trial among 1,800 patients where we were evaluating an outreach strategy using mailed outreach invitations. And we took a look here if you could incorporate HCC risk as well as a prediction of response, could you do better? Could you actually tailor your interventions to both of those inputs? And what we found here is that you can do this successfully in a theoretical manner, and that this can save, over time, millions of dollars. And so this is really an interesting idea that we would like to push forward over the next few years in terms of incorporating the idea of precision, even in terms of interventions to increase HCC surveillance utilization. So in summary, taking a look at the principles, overall cancer screening value must consider both benefits and potential harms. The concept of precision screening is to apply the right test to the right patient. This can allow tailored strategies, so surveillance intensity would parallel HCC risk to optimize value. And we can also use the same principle to target interventions to promote surveillance adherence. Precision screening does require accurate risk stratification and a choice of accurate surveillance modalities. And I think this is the cusp of us being able to do this. We have emerging risk stratification biomarkers, and we have multiple surveillance tests that should be coming to market soon, and these will facilitate precision screening strategies in the near future. I'd like to thank once again the organizers here for inviting me to be a part of this webinar, as well as everyone who I've had the pleasure of working with over the last several years. Thank you again.
Thank you, Professor Singo, for your excellent talk. So we are moving to the next speaker, Professor So-Young Kim. His topic is New Image Study for HCC Surveillance. Professor Kim is the professor of University of Asan College of Medicine in Asan Medical Center, Seoul, Korea. Professor Kim, please.
Professor Kim, please unmute.
Sorry. Thank you for your kind introduction, Dr. Lee. It's my great honor and pleasure to have the opportunity to give a talk here in this privileged meeting, especially with well-known experts in HCC surveillance. Before jumping into new imaging modalities for HCC surveillance, let me start with a review of the current guidelines regarding HCC surveillance. Although it has been covered well by Dr. Singer's previous lecture, the target population for HCC surveillance is high-risk patients for HCC with chronic viral hepatitis and liver cirrhosis. As you all know, all the HCC guidelines across the world recommend ultrasound with or without alpha-fetoprotein every 6 months in these patients. The benefits of ultrasound as a surveillance tool are huge. Among the modalities of liver imaging, ultrasound is the least expensive and the most widely available. In addition, we don't need to worry about risks related to radiation or contrast agent. However, recent studies have raised concerns about ultrasound sensitivity to detect HCC at early or very early stages. According to a recent meta-analysis, which was also demonstrated by Dr. Singer, including 15 studies, the sensitivity of ultrasound for detecting early HCC was only 47%. Do you really think it's good enough, although the number is just roughly similar to the probability of flipping coins? To make it worse, the target lesion in the previous meta-analysis is early HCC according to the PCIC stage system. However, the target lesions for HCC surveillance, particularly in a non-transplant setting, are in fact smaller ones, specifically smaller than 2 centimeters, as known as very early HCC. I suppose you already know the importance of HCC smaller than 2 centimeters. The size of the lesions is one of the most important predictors of clinical outcomes after local regional treatment. Pathologically, HCC smaller than 2 centimeters are known to have less aggressive and less invasive biologic behavior due to the absence of microvascular invasion and lower proliferative profiles. Thus, HCC smaller than 2 centimeters is the main target for HCC surveillance in a non-transplant setting in Asian countries, including Korea. So what is the diagnostic sensitivity of ultrasound for these lesions? There are 2 recent prospective studies from Korea which evaluated diagnostic performance of ultrasound to provide ultrasound sensitivity information regarding very early stage HCC. The first study is the previous study from Korea, which was performed in my institution. And the second one is from Seoul National University Hospital, Seoul, Korea. Let's take a look at the study outline of the previous study. We prospectively enrolled more than 400 patients with annual risk of HCC more than 5%. Diagnostic performance of complete MRI with EOB was compared to ultrasound intra-individually. Here are the results of the previous study. In 43 patients with HCC, 75% of them were at PCIC stage 0, very early HCC. The mean size of 48 HCCs were 1.6 centimeters. The sensitivity of ultrasound was disappointingly low, as it was less than 30% for sensitivity to detect all HCCs, while complete MRI with EOB showed 86% of sensitivity. This difference held true for stage 0 HCC. Also, the specificity of complete MRI was significantly better than ultrasound. The second study was from Seoul National University Hospital, Seoul, Korea. The study design of this study was almost identical to the previous study. They included 100 39 patients with annual risk of HCC more than 5%. Instead of MRI in the previous study, this study compared biannual low-dose CT and biannual ultrasound intra-individually. As you can see here, the size of the HCC in this study was similar to the previous study. Among 24 HCCs, 17 of them were at very early stage. The sensitivity was 29% for all HCCs and only 70.7% for very early HCC, which was even worse than the results from the previous study. A study using explanted liver as a reference standards revealed the sensitivity of ultrasound was affected by lesion size. Thus, when it comes to HCC smaller than 2 centimeters, the sensitivity of ultrasound is markedly decreased. You may think that contrastness ultrasound can be a solution. Here is an example. There is an HCC about 1 centimeter in size in the right trabecular liver. On CT, however, the lesion is not detected on grayscale ultrasound. However, after contrast injection, contrastness ultrasound beautifully detects the lesion in the right trabecular liver. The introduction of a new contrast agent, Sonazoid, provides use opportunities for the use of contrastness ultrasound as a surveillance tool for HCC, as it allows stable post-vascular and Cooper phase imaging, which maintains more than 60 minutes. It provides enough time for entire liver to be interrogated, as well as better visibility of focal hepatic lesions. 2 prospective studies, one from Korea and the other from Japan, tested the performance of Sonazoid in as ultrasound in a surveillance setting. The multicenter study from Korea failed to observe an improvement in the detection rate of early stage HCC, but Sonazoid-enhanced ultrasound significantly reduced the false referral rate compared to conventional B-mode ultrasound. The Japanese study took an interesting approach, compared the size of the detected HCC on contrastness ultrasound to B-mode ultrasound. Although they found that HCC detected on contrastness ultrasound was smaller than those on B-mode ultrasound, this study did not provide the sensitivity and specificity of its imaging modality. The performance of Sonazoid-enhanced ultrasound from these 2 studies do not seem so promising. I suppose these disappointing results of contrastness ultrasound can be attributed to the poor visualization issue. In our daily clinical practice, we sometimes encounter patients with poor sonic window like these figures. Through the subcostal and intercostal approaches, the liver cannot be sufficiently evaluated, as the liver was shrunken due to liver cirrhosis. The LIRAS suggested an ultrasound visualization system. It classifies the degree of visualization of the liver into the 3 different categories. In category A, it means that limitations are unlikely to meaningfully affect sensitivity. In score C, however, limitations significantly lower sensitivity of focal hepatic lesions. So can you guess how frequently we encounter insufficient ultrasound scored as C? From the previous study data, we found that almost 30% of ultrasound scans were regarded as score C. It's quite mind-boggling, isn't it? In this patient, is it okay to stick to ultrasound as surveillance tool, even though it looks like aiming targets without seeing it? We also evaluated changes in the imaging quality of ultrasound during follow rounds. As you can see here, the majority of patients with inadequate ultrasound on initial ultrasound persistently show inadequate imaging quality on follow images. Recent evidences regarding the limited performance of ultrasound in HCC culminated some interesting changes in the major HCC guidelines, which were revised in 2018. All the major guidelines from Europe, the United States, and Korea allow the use of an alternative surveillance tool, such as CT and MRI, in selected patients with a high likelihood of having inadequate ultrasound. Alternative strategies other than ultrasound include complete EOB MRI, CT, and variable forms of abbreviated MRI. This excellent study from Seoul National University is the pioneer study investigating the performance of low-dose CT as a surveillance tool for HCC with a proper prospective study design. This study showed the sensitivity of CT for detecting very early HCC is 82%, while ultrasound shows less than 20% of sensitivity. It also shows the specificity is very high to detect HCC when they used two-phase low-dose CT. However, regardless of the performance of ultrasound for this purpose, it has its inherent drawbacks. Given the repetitive nature of the surveillance tests, radiation and contrast hazard cannot be ignored. Although nobody would deny the excellent diagnostic performance of complete MRI with the EOB demonstrated in the previous study, long examination and interpretation time, as well as higher cost, still hampers the widespread use of complete MRI as a surveillance tool. To overcome some of the barriers of complete MRI, investigators in recent years have proposed abbreviated MRI protocols. The central concept of abbreviated MRI is to reduce longer MRI protocols by eliminating unnecessary or redundant sequences that negatively affect time and cost while maintaining the diagnostic performance. Some suggest that focused MRI is a better term, as abbreviated MRI is suggestive of missing something out. Whatever the term is, the main purpose is to reduce sequences. There are 3 protocols of abbreviated MRI, including hepatobiliary phase abbreviated MRI, dynamic contrast enhanced abbreviated MRI, and non-enhanced abbreviated MRI. This is the standard protocol of complete liver MRI using EOB for diagnosing focal hepatic lesions. As you all know, it includes many sequences. Some of the sequences, such as diffusion-weighted imaging and hepatobiliary phase imaging, are important to detect focal hepatic lesions, while the other sequences, such as dual echo, T2-weighted imaging, or dynamic phase imaging, are crucial for lesion characterization. So in abbreviated MRI, some essential sequences for detecting and characterization of focal hepatic lesions are selected. For meta-analysis regarding the diagnostic performance of abbreviated MRI, all published in last year, reflect the increasing attention of abbreviated MRI as a surveillance tool. All the studies found the sensitivity was more than 85%, and specificity is more than 90%. However, it should be noted that considerable numbers of the included studies were conducted in a diagnostic setting in which the complete liver MRI were originally indicated for those with known or suspected liver lesions, which likely caused the selection bias and overestimation of the sensitivity of MRI. HBP MRI includes hepatobiliary phase imaging and diffusion-weighted imaging, as well as T2-weighted imaging. Hepatobiliary phase and diffusion-weighted imaging are known as the most sensitive sequence to detect HCC, and T2-weighted imaging is required for lesion characterization. The examination workflow can be simplified by injecting EOB in the waiting area, not in the MRI unit. By including the 2 most sensitive sequences, HBP MRI show the highest sensitivity among the AMRI protocols. As you can see here, 2 regions of hepatobiliary phase imaging was noted as low signal intensity. The larger region is considered positive, as the region shows intermediate signal intensity on T2-weighted imaging and high signal intensity on diffusion-weighted imaging. The smaller region here is likely to be assessed due to its bright signal intensity on T2-weighted imaging. It requires additional record tests, including dynamic information, if positive findings like this is noted. Among abbreviated MRI protocols, HPP abbreviated MRI is the area of active research. The sensitivity is more than 80% and specificity is more than 90%. However, all of them are retrospective studies and the sensitivity could have been overestimated. There are some issues in HPP abbreviated MRI. Hepatobiliary phase imaging is influenced by liver function, can affect lesion conspicuity on hepatobiliary phase imaging. Vascular thrombosis can be missed. There are potential harms related to contrast agent. In addition, false positive findings might be relatively high on hepatobiliary phase imaging, as hepatobiliary phase hyperintensity can be seen not only in HCC, but also in any focal lesions with reduced expression of OATP8 transporter, including precursor lesions. Dynamic contrast enhanced abbreviated MRI is composed of dynamic sequences only. The major advantage of this strategy is that it can demonstrate the major features essential for HCC diagnosis. If the lesion fulfills LR5 categories like this case, an HCC diagnosis can be made with this image only without the need for further confirmatory tests. Another advantage is that vascular thrombosis can be detected and characterized. However, contrast-related issues cannot be ignored in this approach. There is only one dynamic contrast-enhanced abbreviated MRI study, to my knowledge, in a surveillance setting. This is a retrospective study including more than 200 patients. Sensitivity was 86% and specificity was almost 100%. However, the authors included not only dynamic contrast study, but also T2 and diffusion-weighted imaging. Thus, I'm not quite sure that it can represent the true performance of the dynamic contrast-enhanced MRI. Of late, many studies won the GAD accumulation in tissue after repeated dose of MRI contrast agent. As you can see, the increased signal intensity in the basal ganglia, which means the GAD deposition after repeated injection of GAD contrast agent is noted. It more commonly happens in linear contrast agent. Therefore, European Medicines Agency has banned the use of the majority of linear MRI contrast agent, though linear EOB are allowed to be used owing to their unique diagnostic roles. We need to be aware of potential harms of GAD-based MRI contrast, including body accumulation and nephrogenic systemic fibrosis. In this regard, non-contrast MRI looks very attractive as a surveillance test, as there is no need for contrast injection, which eliminates contrast-related issues, as well as saves cost and time. We can detect and characterize the lesions using T2-weighted imaging and diffusion-weighted imaging, as you can see here in this case. In this approach, diffusion-weighted imaging should play an important role to detect lesions, but sometimes the image quality of diffusion-weighted imaging can be unsatisfactory, as diffusion-weighted imaging is prone to many artifacts. Vascular thrombosis cannot be well evaluated. If the lesion is detected, additional recall tests are needed. The sensitivity of non-enhanced MRI was lower than 80%, which was a bit lower than other AMRI approaches, while there were a wide range of values. The specificity was very high. Here is a summary of today's talk. Evidences of clinical feasibility of advanced imaging modalities other than ultrasound are rapidly accumulating, owing to the efforts to overcome the limitations of ultrasound for HCC surveillance, especially for very early stage HCC. Contrast in ultrasound did not show promising results. In a performance point of view, low-dose CT was acceptable, while there is radiation and contrast-related issues. Complete MRI showed the superb diagnostic performance. However, long examination and interpretation time can hamper the widespread use of this approach. Thus, abbreviated MRI can be a reasonable solution. Abbreviated MRI approaches can be HPP MLE, DC MLE, and non-enhanced MLE. And each technique has its own pros and cons. Thank you for your kind attention.
Thank you very much, Professor Kim, for an outstanding overview. I think we're going to hold our question answer session till the end of the program. And so we're going to move on, and it's my pleasure to introduce Professor Toyoda from the Agaki Municipal Hospital in Japan to speak on biomarkers and HCC surveillance algorithm.
Okay, thank you for your, thank you very much for giving me the opportunity to have a presentation at this meeting. I'll talk about the use of biomarkers in surveillance for HCC. In my talk, I will present three subjects. First, AFP and other biomarkers. Second, different HCC biomarkers by etiology. And third, the combination of biomarkers. This is world body recommendations for HCC surveillance. Main academic societies for hepatology recommended semi-annual surveillance with ultrasonography and AFP as an optional. In contrast, Japanese recommendation includes three markers, the measurement of AFP and PIVCAT2 in addition to AFP. Three tumor markers are routinely available in current clinical practice in Japan. Alpha-fetoprotein, lens culinaris agglutinin active fraction of AFP, and protein induced by vitamin K absence, PIVCAT2, also termed DCP, this gamma carboxyprothrombin. AFP and DCP elevation is sometimes observed in HCC patients with normal AFP. I will show the case. The patient was a 68-year-old female. She had been infected with HCV and with F3 liver fibrosis. But she achieved SVR by direct-acting antivirus on March 2016. She continued a regular hospital visit every 6 months after achieving SVR for surveillance of HCC. On September 2020, 4.5 years after SVR, her B-mode plain ultrasonography study at her regular visit detected no evident hepatic nodules. However, the sudden increase in the sudden elevation of the AFP-L3 was found on the laboratory examination at the same day of ultrasonography. In contrast, AFP and DCP remained normal range. I immediately planned to conduct dynamic CT at the same day, which revealed the presence of HCC a tumor just next to gallbladder. In this case, only AFP-L3 elevation suggested HCC development and triggered cross-sectional study. When I see the change of AFP and PIVCAT2 carefully and retrospectively, there were minute increase in these values. But it will be difficult to consider them as the increase of tumor markers. Usually, we recognize this as a normal fluctuation. This case was similar to the case that Professor Sim presented previously. His case showed similar change of AFP. She underwent hepatic resection and the diagnosis of HCC was confirmed pathologically. Because the interval of her regular visit was 6 months, HCC might have progressed if I had missed this detection. So AFP, L3, and DCP can sometimes help to detect HCC in patients with absent hepatic nodules on ultrasonography images and normal AFP during surveillance. Next, I talk about the difference in biomarker profiles by etiology, especially focusing on non-viral HCC. The percentage of patients with non-viral HCC is increasing continuously in Japan. This will be the same in other Asian countries, I imagine. This will be partly due to the prevention of new hepatitis viral infection and partly due to the emergence of effective antiviral drugs. In our previous study, surveillance is less effective for the detection of non-viral HCC. These changes in tumor size at the detection of HCC between the period of 2000 to 2006, 2007 to 2030, and from 2040 to 2020. While tumor size was getting smaller at the diagnosis in viral HCC, it was constant in non-viral HCC during the study periods. Also, the percentage of multinodular HCC at diagnosis decreased in viral HCC, but it did not differ in non-viral HCC. Consequently, the overall survival rates were getting higher in patients with viral HCC by the period, but it did not differ in non-viral HCC, unfortunately. This may be partly due to the difference in HCC tumor marker profiles, namely, AFP may be less effective in case of non-viral HCC. Therefore, we compared HCC biomarker profiles between viral and non-viral HCC. In addition, we checked biomarker profiles of SVR HCC that are increasing in recent years. Because tumor marker levels are increasing in association with progression of HCC, we focused on patients with early stage HCC, namely BCLC class 0 or A in this comparison. Study patients were 2,543 viral and 869 non-viral HCC, excluding recurrent HCC, diagnosed between 2000 and 2020. In addition, 220 HCCs in patients with SVR by DAA diagnosed between 2040 and 2020 were compared as SVR HCC. All HCC were BCLC class 0 or A. These are patients' background. Patients with non-viral HCC were more prevalently had habitual alcohol intake and had higher BMI. SVR HCCs were less progressed. This slide shows the serum median levels of AFP, AFP-L3, and DCP with IQR at the diagnosis. In comparison to non-viral HCC and SVR HCC, AFP levels at the diagnosis of patients with viral HCC were significantly higher. In contrast, DCP levels of patients with non-viral HCC are significantly higher than that of viral and SVR HCC. Consequently, the percentage of patients who showed elevated AFP and DCP above routine cutoff differed based on etiology. Whereas AFP elevations were more often observed in viral HCC. DCP elevation was predominantly observed in non-viral HCC with modest elevation of AFP. This may cause less effective surveillance for non-viral HCC. The percentage of patients with AFP-L3 elevation were comparable across etiologies. In patients with SVR-HCC, the percentage of patients with elevated tumor markers were lowest regardless of markers. So the elevation pattern of tumor markers of HCC may differ, and DCP may be more effective in case of surveillance for non-viral HCC. This will support the superiority of measurement of multiple markers for surveillance. Then will the combination of these markers make HCC surveillance more effective? In more than 3/4 of HCC, one or more of the 3 biomarkers shows the elevation. This will trigger the further imaging studies to ultrasonography, potentially increasing the detection of HCC under surveillance. So 3 tumor markers support each other with surveillance of HCC. In addition, theoretical combination of these markers, these 3 markers and patient age and gender may further increase the effectiveness of HCC surveillance. The GALAD model is a score to identify HCC. This combination score showed superior identification of HCC to respective a single biomarker with higher AUROC. The effectiveness with a high AUROC of GALAD score are shown regardless of etiology. You can see higher AUROC in non-viral HCC in compared to the HBV HCC or HCV HCC. Also, this model was effective for SVR HCC. Serial changes of GALAD score under surveillance were compared. The GALAD score was calculated to every visit in 2,273 patients who were undergoing surveillance. So a total 50,433 times point. Among them, HCC developed in 130 patients ultimately. In comparison to patients who did not develop HCC, GALAD score of patients who developed HCC increased gradually. This increase was observed since this is a detection of by imaging modalities. So this increase was observed since around 5 years before the detection of HCC by imaging studies. Therefore, GALAD score dynamics can be used as a trigger to consider imaging studies other than ultrasonography. This is a summary. Biomarkers of HCC other than AFP, AFP-L3 or DCP elevated despite normal AFP levels in some HCC patients. So it may be preferable to test multiple biomarkers in the surveillance of HCC. Biomarker profiles of HCC may differ by etiology of HCC, and DCP may be more useful in the surveillance of non-viral HCC. A combination of multiple HCC biomarkers, including the GALAD model, will increase the effectiveness of the surveillance of HCC. Biomarkers should be more taken into consideration for the effectiveness of surveillance of HCC. Finally, I show a new marker that can be identify patients with pre-HCC hepatic nodules. So this is what Dr. Kim shown, non-hypervascular hypointense nodules on that were detecting during the hepatobiliary phase of EOB MRI. This has a high potential to progress to hypervascular typical HCC. This is non-hypervascular hypointense nodules, and during the observation, typical hypervascular HCC was observed within the non-hypervascular hypointense nodules. A previous study showed that nearly 19% of these nodules ultimately progressed to typical hypervascular HCC. Recently, we found that Wisteria floribunda agglutinin positive MAC2 binding protein glycan isomer M2 BPGI was associated with the presence of this nodule. M2-BPGI was associated with the presence of non-hypervascular hypointense nodule by multivariate analysis and showed highest AUROC for its presence. So M2-BPGI can be a biomarker for not HCC, but per-HCC nodules in patients with chronic liver disease. Patients with elevated M2-BPGI should undergo more intensive surveillance and preferably undergo the EOB MRI. Thank you for your kind attention.
Okay, our next speaker is Professor Zhu Dongyang from Cedars-Sinai Medical Center, Los Angeles, in California. Today, he will give us a talk about clinical impact and cost effectiveness of HCC surveillance. Professor Yang, please.
Hello everyone, my name is Zhu Dongyang. Thank you so much for inviting me to talk about clinical impact and cost effectiveness of the HCC surveillance. This is the outline of my talk today. I'll be discussing benefit of the surveillance, harms of the surveillance, and cost effectiveness of the surveillance. Let me start with the benefit of the HCC surveillance. This is the first and the last randomized controlled trial that investigate the impact of the HCC surveillance in patients with the liver disease. This study randomized the patient into surveillance or no surveillance, and the follow through to see whether HCC surveillance decreased the mortality of the liver cancer. So they randomized about close to 10,000 patients into each arms, and over 38,000 years of the follow-up, the 32 patients had the HCC deaths on surveillance arm, and 54 patients died from liver cancer in non-surveillance arm, with the mortality rate ratio of 0.63, showing that HCC surveillance decreased the HCC mortality. However, this study should be interpreted with caution, as this study was conducted in China, where the predominant etiology of the HCC were non-cirrhotic chronic hepatitis B. Therefore, it is unclear whether this result will be applicable in patients with cirrhosis, especially considering the nodularity of the liver could impact the surveillance accuracy, and also cirrhotic patient population have higher competing risk of the liver-related mortality. After this randomized controlled trial, no other randomized controlled trial was conducted using ultrasound of the liver as a surveillance test. There was an interesting survey study from Australia where they surveyed the cirrhotic patient population and asked if they are willing to be randomized for surveillance versus no surveillance for HCC. Interestingly, most of the participants declined randomization with the belief that surveillance will likely lead to early stage of cancer detection and therefore the improved survival. So authors concluded that the HCC surveillance or CT would not be ethically feasible. Therefore, there's no randomized controlled trial in cirrhotic patient population for HCC surveillance, and most of the study conducted in the literatures was retrospective cohort study that compare the outcome of patient whose cancer was diagnosed under surveillance versus without surveillance. So this is the landmark paper, a meta-analysis of the 47 study that included 15,000 of the HCC patients by Dr. Single, where he showed that HCC surveillance is associated with 2.08-fold increased likelihood of having early stage of HCC and about 2.2-fold increased likelihood of having curative received. What about overall survival? Those whose cancer was diagnosed with under surveillance were more likely to have the prolonged 3-year survival than those whose cancer was diagnosed without surveillance. And also, Dr. Single looked at the study that have evaluated and adjusted lead time biases with the surveillance with the lead time ranging between 70 to 239 days. All of this study shows the beneficial impact of the surveillance in improving survival even after adjusting for lead time biases. However, most of the study in the literature compare the outcome of those whose cancer was confirmed and then compare the survival for those whose cancer was detected under surveillance versus no surveillance. However, there's no large study that compared the overall survival of cirrhotic patient population and who who undergo surveillance versus no surveillance. Therefore, we have performed a marker modeling study with the base case of the 50-year-old man with compensated cirrhosis. We model that a patient can die from the progression of the liver disease or die from natural cause and die from the HCC or HCC treatment. For cirrhotics, can undergo surveillance or no surveillance, and surveillance arm were more likely to have early stage of the HCC, therefore more likely to have potentially curative treatment. So our modeling study shows that HCC surveillance decreased the overall mortality by 5.2% and HCC mortality by 33%. We also performed the one-way sensitivity analysis showing that the liver disease progression and incidence rate of the HCC were most important factor that can affect the impact of the HCC surveillance in decreasing mortality. For those whose liver disease progressed quickly, and they have higher risk of the competing risk of the mortality from liver disease, that the benefit of the HCC surveillance decreased. And also those whose incidence of the HCC are high, the benefit of the HCC surveillance increased dramatically. So let's move on to the harms of the HCC surveillance. HCC surveillance first can cause overdiagnosis, which can be defined as a detection of the disease that would not otherwise become clinically apparent during patient lifetime. So these figures on the right explain about the concept of overdiagnosis of the HCC with the surveillance. So without overdiagnosis, cancer can be detected at an asymptomatic phase that a patient receive the potentially curative treatment and have the prolonged survival. However, when overdiagnosis occurs, HCC detection could occur at asymptomatic phase. However, patient die from competing risk of the mortality. For example, a patient with a Child-Fuse C, not a candidate for liver transplantation, was found to have 2 centimeter single HCC. The detection of the HCC would be overdiagnosis, as that patient died from liver failure, most likely in the next following few months, and HCC diagnosis would not have any impact on patient survival. So why the overdiagnosis occurs? It could be due to inaccurate diagnostic criteria or detection of premalignant or very early malignant lesions, or detection of the indolent tumors, or in the setting of high competing risk of death from liver failure, like I have described with the Child-Fuse C class. So what are the consequences of the overdiagnosis? It can cause the overtreatment and complication, financial and psychological harm. So let's talk a little bit about the physical harms of the HCC surveillance. Physical harm can occur as a result of the HCC surveillance, with the especially with the indeterminate finding on the ultrasound or alpha-fetoprotein, or a false positive finding that patients are subjected to IV contrast enhanced CT or MRI that can cause radiation exposure or contrast induced toxicity. In a more serious case, patient end up receiving liver biopsy, which can cause significant physical harm. So this study from Dr. Singhal, they analyzed 608 cirrhotic patient population undergoing HCC surveillance program, and they saw that the most of the patient had the ultrasound or alpha-fetoprotein based surveillance, that they saw close to they saw like 119 patient had a physical harm out of the 523 patient who had the surveillance ultrasound. This proportion was lower with the serum alpha-fetoprotein based surveillance, with the physical harm occurs in 73 patients. Most of the harms occur with the false positive or indeterminate result. And concluding that 1 in 4 patients had physical harm from HCC surveillance. There are a few other smaller study that describe the physical harms of the HCC surveillance later on. However, there's no study that describe the psychological and social harms of the HCC surveillance in the literature that should be further investigated in the future study. Let's move on to cost effectiveness of the HCC surveillance. Let me start with the terminology of the cost effectiveness analysis, as this will help you to understand the following study that I'll be showing later on. First, gain life years is the additional number of the years of life a person lives as a result of the receiving treatment. In this case, as a result of the HCC surveillance, how many more years they can live is gain life years. Quality adjusted gain life years refers to gain life years, so how many years the patient can live more with surveillance, but after adjusting quality of life index, as a patient with the cirrhosis may not have a full quality of life. Finally, incremental cost-effective ratio, which we call ICER, is the most important, the result in cost effectiveness analysis, which refers to like, how much does it cost to have one quality adjusted gain life years. For example, with the surveillance, how much does it cost with the ultrasound based surveillance to have one quality adjusted gain life years? Traditionally, if ISO is less than 50,000 US dollars, some intervention or treatment is considered cost effective. This figure on the right demonstrates how to interpret the cost effectiveness analysis. The x-axis is the how effective and in the how effective are the intervention or surveillance is, and y-axis is the how expensive some intervention or surveillance tests are, and this line refers to the different ISR. So if there's some intervention or a surveillance test belong under this line, then something is considered cost effective. So this study from Europe that described the cost effectiveness of the HCC surveillance. So in the study, the average incremental cost for ultrasound-based surveillance in cirrhotic patient population was only $891 with French cost and $11,000 with the US cost. Average ISR is only $3,500 per life year gain in French and $46,000 per life year gain with the US cost. So highlighting that ultrasound-based surveillance for HCC in compensated cirrhotic is highly cost effective. More recently, MRI has been being considered as a surveillance test for HCC, given the limitation of the ultrasound-based surveillance, although the cost of the MRI is much higher than ultrasound. So several studies have investigated whether the MRI is cost-effective for HCC surveillance. This study by Dr. Young-Suk Lim evaluate the cost-effectiveness of the MRI in comparison to ultrasound in patients with the cirrhosis and chronic hepatitis B, and in patient with the cirrhosis patient population. So when the incidence rate of the HCC is only 1%, ISR of the MRI-based surveillance versus the ultrasound-based was pretty high at over 100,000 US dollars. However, if the incidence rate increased to 2%, ISR dropped down to 44,000 US dollars, which is considered cost effective. And Dr. Lim also conducted one-way sensitivity analysis demonstrating that the HCC incidence rate is the most important factor determining the cost effectiveness of the HCC surveillance with the MRI, with the ISR of only the 10,000 US dollars when incidence rate is 5%. And similar study was conducted in Europe, where they modeled the patient with the cirrhosis undergoing surveillance with the MRI versus the ultrasound of the liver. And as long as you're willing to pay the 50,000 euro, the MRI is 100% cost effective. And so then the ultrasound of the liver. So similarly, they conducted one-way sensitivity analysis to see what are the main determinants of the cost effectiveness of the MRI surveillance. The again, annual incidence rate of the HCC had the most strongest impact on the cost effectiveness of the MRI surveillance when the HCC instance is 10% per year. The ICER was only 5,000 US dollar per life year gain. On the other hand, when the annual incidence is 1%, it dramatically increased. However, still less than 50,000 US dollar. Sorry, actually not US dollar, but euro. Less than 50,000 euro per life year gain, and highlighting that the HCC instance is the most important factors determining the MRI-based surveillance, and the MRI could be potentially quite cost-effective for HCC surveillance in Europe. In conclusions, HCC surveillance is quite beneficial as it can lead to early stage of cancer detection, curative treatment receipt, and prolonged survival. However, the benefit of the HCC surveillance should be weighed against the potential harms of the HCC surveillance, including physical and psychosocial harms. Especially psychosocial harms should be further investigated in the future study. HCC surveillance is cost-effective. Finally, MRI-based surveillance could be cost-effective, particularly among high-risk cirrhotic patient population. Thank you.
That was an excellent talk, Professor Yang, and I'm sure it's raised many questions amongst the audience. We want to turn finally back to Professor Sin to deliver the final aspects of the case presentation that set the focus for the talks through the evening. So, Professor Sin, back to you.
Thank you, Professor. So back to the case, I will briefly show the clinical course of the case. Before the index visit, he has been regularly receiving surveillance with alpha-fetoprotein and ultrasound or CT. And suddenly at the index visit, his alpha-fetoprotein level was rapidly raised from 3.8 to 129. At this point, he has received ultrasound surveillance and found no suspicious nodules. But as his serum alpha-fetal level was rapidly raised, he underwent immediate CT scan, which found a small arterial enhancing and delayed washout region. The subsequent MR evaluation was confirmed HCC diagnosis. He underwent additional stage workup and received ablation as a first-line treatment. He received ultrasound-guided RFA, and after the procedure, his serum alpha-fetoprotein level was dropped to 21. And this is a follow-up imaging 1 month after RFA. But unfortunately, 3 months after RFA, there was a local tumor recurrence, and the serum alpha-fetoprotein level was slightly elevated. So at this time, he has underwent service proton beam therapy, and after that, there was no evidence of tumor, and his serum alpha-fetoprotein level was decreased back to the normal range. Thank you.
Okay, thank you for all the speakers for the presentations. So we'll move on to the discussion session, and any question from our panelists or the audience? I saw there's one question from Professor. There's a question from Professor George Lau, I think, in the talk. Let me see. Professor Lau has asked any follow-up study in the previous study. Probably this is for Professor Kim.
Maybe I might just echo back. I think this is excellent to have prospective studies in this area, because most of the data are for retrospective studies, and subsequently proved that the C index is not that useful. My questions to Professor Kim and Professor Young's excellent work on the previous studies, because the studies was reported in 2017. And well, this is now 4 to 5 years down the road. And one would be interested to know the follow-up of these patients, which is a prospective studies with more than 400 patients in Korea. Thank you.
Professor King, are you online?
Yes.
Thank you.
In fact, we analyzed HCC patient survivor data who was diagnosed as HCCs in the previous study. As you can see here, there was significant difference in patient overall survival, even though the survivor was followed up only 3 years. And we are planning to report further follow-up data in the future. And of the patient who was not diagnosed with HCC after 3 rounds of surveillance, almost all of them continued to undergo HCC surveillance in our hospital with variable imaging modalities. And the median follow-up data after the last round of surveillance was 40 months. And 38 patients were subsequently diagnosed with HCC at a median time interval of 40 months. Importantly, there was no patient diagnosed with HCC within 1 year at the end of the 3 rounds of surveillance. Thank you.
Thank you very much. Maybe another follow-up question. So do you have a chance to look at the new markers, such as scarlet, reported by our Japanese colleagues on your patients, because you can recalculate if the data is available?
I think Dr. Lim will answer the question.
My question is whether these are biomarkers as presented.
Omata from Japan. Can I answer that, George? Omata Masao Omata from Tokyo.
Yes, Professor.
How are you?
How are you?
Yeah, for the last 30, 40 years, we are kind of choosing the 3 markers I mentioned several times in the APASL, or maybe it's 100 times, that we use AFP and lectin binding protein L3 and DCP. So in the case like just shown today, even though the AFP drops, if the L3 stay high, they tend to recur. So it's a very good marker. And actually, my experience, I don't really need a new markers. In fact, if I miss the case of the cancers, I may have a troubles. But fortunately enough, because of DCP and L3, and then of course AFP, I do not have many blames from patients. So that's my, you know that, I keep saying that. And so I think in this particular case from Korea, it's nice to see the steady rise. But if you add L3, maybe you can make a diagnosis early on. and then patients are happy about.
Right.
That's the comment I have.
Yes, Professor Omato, thank you very much. Very relevant comment, and I fully agree with your opinion. In fact, the patients involved in the previous study has been followed up with 3 biomarkers prospectively, and we analyzed the changes in those biomarkers before the diagnosis of HCC, and all 3 markers showed clear increasing trends before the diagnosis of HCC. And the most important point in our study, which was published in Hepatology several years ago, was that the cutoff value of those biomarkers should be carefully adjusted. Traditionally, we used the cutoff values above 200 for alpha-fetoprotein in the era when we had not good antiviral drugs. And to avoid the first positivity, we used the high cutoff values for alpha-fetoprotein and other biomarkers. However, with very potent antiviral drugs for HBV and HCV, we have greatly reduced first positivity rates, and our study clearly indicated that the cutoff value should be lowered to enhance the sensitivity. And our study suggested 5 nanogram per ml for alpha-fetoprotein would be very nice to ensure the high sensitivity and also the specificity. And also the AFL3, the cutoff value should be lowered than that was known previously. And the TCP should also have a lowered cutoff value about around 20. And with the combination of those lowered cutoff values of all 3 biomarkers when combined with ultrasound, we can ensure about more than 80% of sensitivity in those patients with the cirrhosis. Thank you.
Yeah, I'm very glad that you share the same things about taking care of the patients. And in fact, how's the APL3 values in this particular case that today the Korean colleagues showed us? Did you measure the L3 binding protein for this one, for particular this case?
For this case,
I'm
Sim from Korea. For this case, we only used alpha-fetoprotein before HCC diagnosis. And after diagnosing HCC, we additionally measured PIVCA2 level, DCP level, which was not elevated and did not change during the treatment course.
Sorry, did you measure L3?
Yeah, we didn't measure L3. And
didn't?
Yes. So
that's
in Korea,
a pity, because even the 5 nanograms, 7 nanograms total AFP, maybe L3 can be as high as 20%, 30%. So that's the key things, because if you see the patient with a total alpha-fetoprotein, say 8 nanograms, nobody can make a diagnosis of cancer. But L3 is up like 20%. Usually it's less than 0.5. But if it's up to the 20, 30%, I think very suspicious. And in fact, the alpha-fetoprotein climb up to the 100 nanograms. But maybe before that, we can make a diagnosis. That's what we've been doing for most of the time in our country. So yes, that's what I try to say. Thank you.
Yes, I also agree with Professor Omata's opinion. In most cases, the AFP-L3 levels can be sustained below 0.5%. However, in many of our patients who had the diagnosis of HCC, the AFP-L3 suddenly increased to above 5%. So our study suggested that the cutoff value for AFP-L3 should be 5%. above that level, we have to carefully consider that presence of the HCC, early stage HCC in the patient.
Yeah, thank you very much. You know, we want to discuss about these things in Korea too, but unfortunately, we may not be able to go there. But I really hope to discuss these things. Let me add one thing. You know, when we measure the 3 markers, we say this case is a triple positive or triple negative, just like breast cancers. But there is one unique feature, such as DCP only positive. They tend to have a big one nodule. That's our experience. We published maybe 10, 20 years ago. So, you know, by checking 3 markers, maybe we cannot only have a sensitive markers, but some biological significance we can find. In fact, if DCP positive, they tend to have the portal vein thrombus in the future. That's also we discussed before. So these kind of things is very exciting, and we want to discuss about this in Korea. Thank you.
Professor?
Yes.
I feel that it is difficult to use the AFP as the biomarker for SVR patients because even the cutoff was fixed at 5 nanogram. It is difficult to accurately detect the HCC in surveillance because most HCC are detected in very, very small, less than 2 centimeters, and in SVR patients, it is not so often the AFP elevated more than 5 nanogram. Rather,
Yeah,
I feel that the dynamics of HCC, so the increase or the increase of AFP or DCP or AFP-L3 will be more important in case of the patients treated by the antiviral therapy.
Yeah, I agree with that because my daily clinical practice is only the patients who clear the viruses. So we are checking those patients by using 3 markers, and then that's still useful. That's my feelings because I don't have any HCV carriers anymore in my clinic, but we got to find out the cancer they develop. So in that case, still, I think 3 markers are valid. Sorry about.
Dr. Singhal, I think Shiv Sarin has preempted this discussion and asked you to comment on a recent gut paper that said an AFP of 4.6 leaves a high risk post SVR. And Professor Sarin was interested in your thoughts on this.
Yeah, no, I mean, I think that, you know, it's funny, we give AFP a hard time, but it seems to be a marker that continues to come up and you know, has multiple roles here. You know, AFP, you know, we think of this most traditionally in HCC surveillance, but we have to remember that AFP has traditionally had a role in terms of risk stratification and as a risk marker as well. I think, you know, the other panelists in the prior discussion already remarked on these cutoffs that we traditionally have considered for AFP, both as a risk marker as well as a surveillance marker, are likely outdated. And as we move to a non-viral world, as well as a post-SVR world, I think that you're going to see the inflammation-related AFP levels start to fade, and we're going to have to readjust all of our cutoffs. And so, you know, whether the perfect cutoff is, you know, 4.6 or whether it's going to be some other level around there, I think it's worth noting that these small elevations, I mean, not even elevations, but small levels of AFP can be concerning. And I think one of the other things that stood out to me, not only from the discussion, but even in the case, is that it's not, in my opinion, it's not about one-time levels, it's really about longitudinal levels. And so one of the things that stood out to me is even though that in the case, the AFP level was consistently normal, I think we have to get rid of this idea of what is normal for AFP. At the end of the day, that AFP level was rising. And if at the end of the day, even though it was only, I forget the exact level, but even though it was only 4 or 5, it had doubled. And for us to say that it doubled without any other rationale, to me, that raises the suspicion for HCC. And Dr. Sarin, to your point, I mean, same thing here for a post-SVR patient, depending on where they started, and once again, we'll have more data about normal post-SVR AFP levels. I think these very low level AFPs can still be concerning and will help us determine which patients will be at higher risk, particularly when you start combining this with other clinical features, there's been studies showing fibroscan levels after SVR, so not pre-SVR, but post-SVR levels are predictive of HCC. As I said, there's now blood-based biomarkers. I think we're going to find that we can combine all of these things in terms of identifying high-risk cohorts and really moving towards this idea of precision screening.
Could you say that, before
just 1 minute.
please.
There is a paper by Jessica in JHEP reports where she has classified based on AFP patients as hot or a cold HCC. An infiltrative HCC has a higher AFP. And the text of that paper takes us that you can use immune check inhibitors based on AFP levels. I just wanted to learn from you if that is the case, and what do you do if you have a high AFP? You think it is an infiltrative HCC, that yes, it is a hot tumor.
Yeah, I think that, once again, we do know that, AFP can correspond to the hot versus cold tumors. And so it is a marker, once again, of these different phenotypes of tumor biology, although the correlation with response to immunotherapy is imperfect. And so I think that, there are now other markers that are also starting to come out in terms of trying to find a treatment response biomarker for immunotherapy, particularly for these larger tumors. But I have to say, we've seen the data, for example, from Joseph in terms of lower responses to immunotherapy in NAFLD patients versus non-NAFLD patients. We've seen the data from Jessica in terms of the AFP corresponding to these hot tumors and may basically correspond to response. But I think they're imperfect. And I have to say that if somebody has an infiltrative tumor, we use immunotherapy. Especially now with the doublets, atezo-bev, now with Himalaya presenting, we're going to see LEAP data shortly. I think with these newer data, the responses are so much better and the survival is so much better than our traditional therapy. We use it in patients if they're otherwise eligible. We don't restrict it because they have a normal AFP, or because we don't withhold it from NAFLD patients at this time. We do need treatment response biomarkers. We're just not there yet.
Let me ask other people that in India or China or Korea, are you using, or Taiwan, using a DCP or L3 as a routine? We in Japan, we are using those in routine. So every single time we only talk about AFP. But if you have experience L3 or DCP, I think you may have a different paradigms. I think repeatedly we are doing this for maybe 30, 40 years. And the reason is very simple, because other people not measuring the L3 or DCP, so cannot discuss about. We only talk on the focusing on the AFP. And in that sense, in that context, it's very interesting. But I think we should compare the data by measuring the same things, and then can discuss. Then we can go step forward. How do you think?
I can give you data from our ILBS. We regularly use L3, AFP L3 and PIVCA2. PIVCA2 is very helpful. Sometimes it is helpful when we do not find anything in the CT or MRI as far as the tumor thrombus, and it is high. It is very sensitive marker for high dose vitamin K therapy, which we are using. You give vitamin K, PIVCA comes down, tumor thrombus goes away. L3 is very good, but we were using 15% cutoff. Today I learned you can use 5%, but as a fraction of total AFP, we were going AFP L3 of 15% or about 35. So I would like to know from you and other experts, what should be the L3 level to become concerned? I don't know, but we use it regularly.
Yeah, L3 is the usually less than 0.5, but if it's 10%, 20%, I'm very curious about, I'm very much concerned about, even though total AFP are 5, 7, 10 nanograms. So I think the two ways, longitudinal measurement of both and the combination of the three, that's quite a routine. And then about the nature of the AFP, I think if you may simplify two types of the elevation, inflammation related and cancer related. And since we are, as I said, post-DAA or during the DAA era, we only see the SBL patient getting the cancer. Of course, inflammation related AFP down. So I think maybe we have to cut down the levels of the AFP normal. In other words, inflammation related is gone. Therefore, I think the cutoff level should be lower. I mean, that's kind of simple thing. Is that too simple-minded? Too much simplified?
Yeah.
Dr. Sun, you said you check, L3 and DCP regularly. Do you, I put it in the chat, but do you interpret the markers individually usually, or do you use GALID or both? How are you interpreting?
Almost all the time, 3 markers together.
So you're using it as GALID or something else?
I don't know what's a GALID, but we've been using 30.
Usually in Japan, we are not using GALID routinely. We use 3 markers and compare these 3 markers in real clinical practice in Japan. I think usually it is like this.
Exactly, that's what we do.
May I make a comment? I think that this is a very good collective thinking. The key issues is we want to detect early liver cancer in different eras as previously. We are now having DAAs with complete cure on Hep C and also nukes suppressing the HBV. And I think that it's now the time to really look into our data, because the mortality incidence ratios in a lot of the regions remain the same. And I think this is the ultimate. When we talk about the screening, and I realize there's a lot of reports with different risk score, but then when we look at it in the real life, sometimes there is a little bit of discrepancy. And I think the reason is because these are retrospective studies. And the definitions of the events, because we all depends on the time to events analysis, the occurrence of HCCs and the staging of the HCCs is not really included. I concur with Professor Omata on using free markers, and I want to answer his questions in addition. In China, in mainland China, we use all the free markers, but in Hong Kong, we use the alpha-fetoprotein alone. My personal experience practicing in Beijing and also Hong Kong, alpha-fetoprotein, nowadays we are talking about those with normal ALT. And I think that it's really reduced a lot of noise about our previous definitions of 20. Having said that, I think that the value itself is significant because different patients might have different levels of normal alpha-fetoprotein. And I concur with Professor Singer. The fluctuations of the AFP itself is very important. I have quite a few early HCC detected based on an elevations of alpha-fetoprotein, even in a single digit, within normal range. And then which actually alert us for further investigations, MRIs, and benefit with early resections with long-term survival. And I think that we need a collective effort here, facing with a new era in hepatology, with hepatitis B completely controlled with nukes, with HCV controlled with DAAs, but then compounded with newcomers, and that is fatty liver. So I think that we need to maybe to work out a new algorithm of early detections with reductions in the mortality incidence ratios. That's my comment.
Dr. Lau, I completely agree. I think the only thing that I would add on is those studies ideally need to be done prospectively when you're thinking through biomarkers, in part because of exactly this idea that when you take a look at these retrospective studies that have examined these biomarkers, they use traditional cutoffs. And they will examine AFP at this cutoff of 20 nanograms per milliliter, and then do not account for the fact that we as providers are smarter than just looking at a single, AFP level and saying yes or no. And so as providers, when we start to see elevations, like slowly rising elevations, you'll act upon that and you'll find it earlier than just crossing that 20 mark. Likewise, if you see patients who have a stable level of 50 and then 45 or 40 and a declining AFP, we're not going to order a diagnostic evaluation because that AFP level is reassuring by dropping. And so I think traditional studies have actually been harsher on biomarkers than they have on ultrasound and imaging. And so I think that those studies, when you take a look at biomarker performance, whether AFP alone or whether in combinations with DCP, L3, other markers that are going to be coming to market, I think those prospective studies are going to be critical because of this added on provider interpretation.
It's so easy to
question
say
for-
to have a prospective study, but in reality, that some studies saying the patient refused. So I think it's not practical. I've been in this field for 50 years, and then we talk about AFP a lot, 1,000 times, but it's not so simple.
Professor Sarin, your hand is up.
Yes, I just wanted to ask Professor Yang and maybe other colleagues, any predictive model for development of HCC in NASH, especially lean NASH? In one clinic, we see now close to 8 or 10 HCCs every clinic. And we have just guesswork for this. No AFP, nothing is there. So I wanted you or maybe others, if not, maybe we should start a large study to see and collect these biomarkers. So Professor Yang and maybe.
Yeah, briefly, I think that Dr. Single shows several models predicting HCC and incidence or risk stratification in cirrhotic patient population. So there are some clinical model and the incorporating traditional risk factor, including gender and age, diabetes, and other risk factor to predict the HCC incidence. But more recently, over the past few years, there are some genetic risk score that can predict the risk of the ACC in patients with the NASH and NASH cirrhosis. So I think that the field is moving very rapidly, and in terms of the risk stratification, who will likely develop HCC. I think that this is a very important question, especially in non-cirrhotic NASH population, because it's so common. Prevalence is 30% in many parts of the world. So, but at the same time, their incidence rate of the HCC is so low, actually, that we can justify the routine surveillance program. So I think that this is the key area that we need to improve. Risk stratification of the HCC in non-cirrhotic NASH is really an unmet need.
I think the only thing that I would add, Judong, is the fact that I had referenced this blood-based biomarker that Yujin Hoshida and his group have started to push out. So they have an etiology agnostic risk stratification marker, this PLSEC AFP that was published this past year. And I had referenced the fact that they now have etiology specific add-ons that are being developed. And so that will be presented later this year, where they have a NASH specific add-on that is complementary to PLSEC AFP. And so when you use those two in combination via this blood-based biomarker, you're able to risk stratify people into 3 different groups, into a very high risk group, an intermediate, and a low risk group. And that low risk group actually has an incidence of 0% over, with a 3-year follow-up. And so they've validated this in 2 cohorts so far. And we're sort of now trying to push out and validate this in other cohorts moving forward. But I think that, as Dr. Yang was mentioning, I think these clinical risk scores are useful. These polygenic risk scores are useful. But when you take a look at the C statistic, the C statistic is good, but it's still 0.7. And then as a clinician, you're like, there's a lot of actual sort of misclassification. And so, how good does that model have to be for you to say, I'm not going to do surveillance or I'm going to do something more intensive. And I think what we need to do is get those C statistics to be much higher, where we can feel comfortable, taking this out of the journals and actually putting this into the clinic. And so that's where I think clinical risk models aren't going to be sufficient. And I think that we need to come up with something more nuanced. And that's why at least our group has been very aggressive in terms of trying to evaluate these, these secretomes in terms of, a blood-based biomarker that can hopefully push this up higher. But Dr. Serino, clearly an area of need. We need to find these high-risk, non-cirrhotic patients who we can put into surveillance programs, equally as much as we need to sort of find the low-risk, cirrhotic patients post-SVR, who we can be like, you don't need to do indefinite surveillance, and Hep C cure from seeing your hepatologist.
Are there any other questions from the panel members or the audience?
I think there's a question in the Q&A just in terms of which risk stratification scores are promising. I know we just went through some of this for the NASH. I think it's worth pointing out that there are several risk stratification scores for hepatitis B. I pointed out the page B score. There's, the REACH score in terms of other, risk stratification scores in hepatitis B. I think that the key thing, as we mentioned, is with everyone on antiviral therapy, these scores, several of them have been validated in patients on antiviral therapy, but those are the ones that are most promising, obviously, moving forward, given the high use of antiviral therapy in clinical practice.
Professor Kim, I was going to ask, and Professor Yang, we're all constrained by healthcare budgets, and that is a big factor in the surveillance strategies that we use. If there was no restraint in budget, what would your strategy be for surveillance?
Yeah, I think that's a great question. In terms of the surveillance and cost effectiveness of the surveillance program standpoint, I think that accuracy, as I have shown, or Dr. Kim shown, the MRI seems to be much more accurate than the ultrasound or serum alpha fetoprotein. So I think that seems to be much better in terms of the detecting liver cancer than all these stage, no argument. But the high cost could potentially be an issue. But I think the one thing that I would like to emphasize is that as I've shown in cost-effective analysis, the ICER with the MRI-based surveillance is not super high, even with the incidence rate of the ACC set up at 3%. It's way below the $50,000 US for 1 year of the quality. But remember, many of the immunotherapy, the cost-effectiveness analysis in ACC, none of them are cost-effective. All the TKI and immunotherapy is way above like $200,000 US dollars or above to have the 1 year of the survival improvement. So in context, I think that the MRI-based surveillance, especially in high-risk patient population, makes sense. Even after considering the societal financial constraint, I think that makes sense, especially and the future direction should be how we can minimize the cost related to MRI with the abbreviated MRI or some innovative way that we can decrease the cost and make it more comparable to ultrasound as the future direction. But even now in the current setting, I think that use of the MRI seems to be very reasonable in high-risk patient or patient listed for liver transplantation. And that is our practice. We use MRI a lot in our clinical practice, especially in the US, where a lot of patients have the abdominal central obesity and ascites that can affect the quality of the ultrasound-based surveillance. So maybe half of my patient with the cirrhosis have the MRI-based surveillance, or at least MRI alternating with the ultrasound. And I don't usually have any resistance from payer insurance company covering that.
Professor Kim, would you like to comment?
I completely agree with Dr. Yang's opinion. And in terms of cost of MRI, I believe that in the near future, the time of MRI acquisition will be, definitely reduced by introducing new techniques such as deep learning or other imaging techniques. So the, image acquisition time for MRI, if the image acquisition time of MRI is reduced, the cost effectiveness MRI would be further, increase, further decrease. Thank you.
Professor Lin, I think it is almost time to close the meeting. Are there any comments before we ask Professor Yang to close the meeting from yourself?
Yes. Okay, just I think time is limited, so probably we will invite the president of APASL, the Professor Yang, to give closing remarks.
Yeah, thank you. The Professor Lin, at the Seoul meeting, my presentation is next to Hepatology carcinoma, so we can discuss at the time detailed portion. So thank you to everyone who participated in the APASL webinar. APASL webinar held once a month had the highest participation rate compared to the other webinars. I'd like to express my gratitude to the APASL steering committee members, Professor Young-Sung Lim, the chairperson of the APASL webinar committee, Ms. Izumi, secretary of APASL, and APASL members who participated so far. Lastly, see you at APASL 2022 Seoul annual meeting at end of March with good health, even though COVID-19 pandemic. As I told you, the Seoul meeting is impersonal. Maybe the COVID-19 situation is much improved. So see you in Seoul. Thank you.
Thank you very much, Dr. Yang, Omata. Darrell, thank you, Darrell.
Thank you. Thank you very much.
Dr. Kim, thank you very much.
Thank you.
See you soon.
Congratulations.
Oh,
Thank you.
good to see you soon,
Keep
everybody.
safe.
Bye
See you.
bye.
Take care.
Good night. Good night.
Thank you.
Good
Bye.
Thank you.
Thank you.
Hi.
Bye.
Hi, Dr. Yang. Right.
Thank you,
Good.
sir.
Bye, Steve. Thanks.
Bye.